There's going to be a few different things I'm going to talk through with you this morning. But before I do so, it's really important to acknowledge important people, particularly the traditional owners of the land on which we're meeting today, and acknowledge Aboriginal elders of the past and the present, and indeed of the future, and of course of any Aboriginal Australians here with us today. Also, I'd like to particularly acknowledge David Malone, the CEO of APNA. What a fantastic conference, David. Brilliant work. Andrew Wilkie, MP. If all of our MPs thought as clearly as you, Andrew, our health agenda would be much advanced. I've already asked on Twitter Michael Marmot to send you that 150 copies of his book to share with your federal colleagues. And of course, Sanchia Iranian, and that leads in particularly for me to something very, very personal, actually, Sanchia, because I wouldn't be stood here today if it wasn't for one germ of a simple idea, of an elevator pitch, which was created by a majestic mind, which is sadly now departed, Sir Nigel Gray, the previous CEO of Cancer Council Victoria, and he had a great idea back in the late 1970s, and that great idea was a very simple thing. We should get taxes on tobacco, because that will drive down usage. But not only that, we should take that money and we should use it for better health outcomes. And we can do that by putting it into a health promotion foundation. And that health promotion foundation will buy out tobacco advertising from sports and from arts that was rampant at that time. It's pretty hard to remember. There's a few nodding heads, but there's a lot of people who just can't imagine how prevalent it was at that time. That basic idea worked. After 19 years, I think, was the case of lobbying. I think it was 8 separate health ministers that Sir Nigel and others lobbied over that time to create Vic Health. And Vic Health exists, and it continues to exist to this day. 30 years later on, I'm privileged to be somebody who's got an opportunity to work at that organization and try and carry that heritage forward. And I know David from, in fact, his time running as CEO of Healthway in Western Australia, which is the Western Australian equivalent of that. And for your information, there is about 15 international health promotion foundation agencies based across the world, modeled on that core idea, most of which are in the Western Pacific region. Why? Because we've run a very small and focused capacity building program through the Western Pacific Regional Office of the WHO, which has built the capacity within countries of teams to think about how do we fund health promotion? How do we, in the world of demand, where, urgent things are happening, people are dying, there's terrible things happening, how can we carve out a little bit of space where we really think about what I'm going to be talking about with you today? And I'm absolutely privileged to get to think about this all the time, and I'm privileged to be here talking with you because you're already doing it. You're already living it. It's not complicated. So much of nursing practice, I'm going to be telling you stuff that you already know. So apologies for that in advance. I'm just struggling to find the clicker. Is this the... No lit matches. I don't think there's anything there which isn't entirely flammable, both the hair and the clothes. Just wonderful. It makes me want to go back to my youth. I know that you can say, oh, Bruce, it's a bit gendered, it's a bit... I love it. I think that's wonderful. Sancho, absolutely, hear what you were saying. We need to progress the narrative around nursing. I love nursing. I'm not a nurse. I absolutely love nursing, and I'm sure my attitudes reflect those of the general community. And because we're talking about health promotion, and because you're all nurses and you will understand, I'm going to ask you to do what those lovely ladies are doing. And please stand up. And the reason that I've asked you to stand up is, of course, this is a workplace. This is a workplace. It's a workplace for the fantastic organizers who've put it on. Round of applause for them. It is most assuredly a workplace for all of the people speaking today. Give a big round of applause to them. And it's also a workplace for everybody in here. It might not feel like you're working, but you are. Everything that you take out of this wonderful event over the last couple of days, from arriving in Hobart to going to the incredible Mona last night, which I found just amazing, the most amazing Australian art that I've seen full stop in my lovely 10 years that I've been here in Australia. Just incredible achievement. And what you'll be learning today, please take that back, and that is your work. And taking back those key messages is your work. Or at least I'm giving you that task now anyway. I'd like you to think also, just briefly, about one thing that has made you smile today, and share that with the person standing next to you. Okay, before we get too carried away, I'll bring you back around. Shh. Shh. It's amazing. That's an incredible technique. Public speaking tip I once got given. If you want to quieten a room, just go shh. It's incredible. It works absolutely every time. Now I'm going to stop you being shh and I'm going to get you active again because I'm going to take a video of you so that I can put that up on my Twitter feed later on today and share that with my colleagues to see how active the primary nursing community here is in Australia. And to do that, I'm going to count 1, 2, 3, and I'm going to want everybody, please, to say, APNA 2017 rocks. Go! APNA 2017 rocks! Thank you. You can all sit down. Thank you so much for that. So what I want to talk with you about today is the kind of most obvious bit of like everything you've heard. You've heard about so many complicated things that are hard to get your head around. I'm going to take us right back to the beginning, and I'm going to ask one question. What is health? Okay, what is health? You've probably got a definition in your mind. You know, there might be some stuff you've read, or there's certainly stuff that you'll be practicing all the time, okay? I'm going to chuck up some images, and I want to ask you, are those images, this is crowd participation time, so I do want people to say yes or no, please, okay? Clue, the answer is no. I'm going to show you some images and say, is this health? Come on, you can do better than that's not health. No, that's not health. Well, health, of course, is a state of complete physical, mental, and social well-being, and not merely the absence of disease. And normally in health promotion, I do a lot of health promotion talks, as you can imagine, in my role working at Vic Health, and normally we accompany these images of health promotion with what I refer to as the image of somebody gambling down through a field, possibly of sunflowers or otherwise, you know, leaping around in a leotard or otherwise exuberantly expressing life. I took this photo on my first day arriving in the southernmost latitude I've ever made it to. So this is the first time here in Hobart, and the first time at this latitude. If I get any further, I'll have to get on one of those boats to go onto the Antarctic mission. And that was the sign that I saw on the way in. And it said, welcome to Hobart. I just loved the orange light against the black sky. I just went, that's beautiful. That made me feel happy. And that is being healthy. So that's why my little shot there is of my little moment here joining Hobart. So, next question. What is health promotions? Yes and no's, please. Is this health promotion? I'll have to give the next one, you'll have to read it in a little bit more detail, the next one. Is this health promotion? No, no, no to both of those. Neither of those is health promotion. What is health promotion? Health promotion is the process of enabling people to increase control over and improve their health. Now, the word I want to emphasize there, the BART word, is process. Process is not a dirty word. Health is not an outcome as much as we measure them. Health is a resource for life. We can change, maybe, the time that we'll die. We can change the odds of what we will die of. But we cannot halt that inevitability of death. Health is a resource for a good life. It is not life in and of itself. It is a component of life. It's not an outcome in and of itself. As much as it's extremely important to have money to spend on hospitals and all of these different things, we often forget the fact that health is not an outcome in and of itself. It is a resource for life, and that health promotion is a process. What that means is, and the reason I wanted to use the good old images of, because in my barbecue pitch conversation, in my lift elevator conversation, the first thing, what do you reckon I get? What's the first thing? Health Nazi. Nanny state. Oh, the nanny state. Oh, here you are, telling us how to live our lives and be miserable, grinding our way to the graves. Why is it, Bolam? You should be telling us how to live. Well, the answer is, of course, we're not. We're not interested in trying to do that, because my pitch would be, you know how most of the disease and death and disability in this country is driven by things that we could prevent. You know that? Well, that's the case. And so what we do is we try and build healthier environments so that the healthy choice is the easy choice. That's what health promotion is about. So how do we do that? That's where I'm going to be dwelling most of my attention today. And the big thing I'll be saying to you is, don't worry. It doesn't demand all the time incredibly complicated work. It doesn't mean that you have to be constantly referring to somebody else who knows more than you. And the good news is, the best news is, you're already doing it. I just need you to do more of it, or we need you to do more of it. So how do we do it? Well, good news is we don't need to rewrite the rule book. It's already been written. It was written and published in 1986. I've had the privilege of working with some of the people who wrote that Ottawa Charter in 1986, a WHO charter, which looked at health promotion and said, well, what really, and then for many of these people, they kind of say, public health, often when we talk about public health, we think about drains, we think about infectious diseases and immunization and things like that. And at that time in 1986, people called out the fact that what we need is a new public health. And it's only new. It's not new because it's not doing anything different. The only thing which is new about it is that it's about promoting a positive sense of health. Yeah? That it's not just the deficit model of health being defined by death, disability, and curative services. When we say health services, what we actually mean is curative or rehabilitative services for ill, sick, or disabled people or bodies. We don't mean health services. Hence why I've called out today the purpose of my talk being around putting the health in healthcare, which is an absolutely critical role that nurses, of course, play. So I'm not going to talk about this in a massive amount of detail, but just to kind of summarize the whole model of health promotion and how do we do it. Because then the next question is kind of like, oh, Bruce, gee, I like a beer. I like a beer. Like, shit, like, you guys, you women, like, are nuts good now? Are they good or are they bad? Like, you can't make your mind up. I read one thing the other day, it said nuts were great. Then the other said, they've got fat in them, right? They've got too much energy in them, and they're bad. You people can't get your act together, right? To make up what the prescriptions are to make me more miserable, right? To make my life more miserable. So that's one thing which is about developing personal skills, right? That's the middle one there. Developing personal skills, so that people have got the skills to take control of their own behavior. But if you try and do that on its own, is it going to work? Good luck. Good luck. Because our behaviors are complex, they're rooted in our past, they're rooted in our environment. Much of it is outside of our conscious control. We just do things because we always bought that brand of butter, or whatever it would be. My mum did it, like that's how I do it, right? Try unpacking that complexity on an individual level alone with a patient. Good luck. Like, we'll make some wins, but it'll be phenomenally hard. Around that, we've got to think about the supportive environments around that. And often in health promotion, we talk about where we learn, live, work, and play are the places where health starts and ends. Where we learn, live, work, and play. And those environments and how they're structured has a huge impact on our behavior. Hands up, confessional moment, anyone who's had a mint yet from the table this morning? That was a behavioral nudge you have been put into that almost every single venue I've ever gone to does. It's a nudge. Did you think about it when you choose that? You probably sat there and went, oh yeah, that's nice. It's a bit like when I get home, and I'll get home from my flight tonight, and I'll go in and I'll open my fridge door, and I'll look in the fridge, and right smack at eye height is a beer. Gee, I'm feeling thirsty. I am feeling thirsty. Oh, I've been working hard today. What's interesting in all of these things is that our reptilian brain, our limbic system, is thinking for us. And our cognitive brain, right up the front of the prefrontal, the cortex, all the good stuff, is coming later to the party and putting a veneer of rationalization over it. Right? We're explaining to ourselves, oh, I've earned it. Yeah, I've earned it. It's not just because me, like everybody else, is a biological being, conditioned into responding. And if I put a plate of little sweet treats in front of you, which taste great, you're going to say unconsciously, I've earned it. So we've got to think about how supportive the environment is for that. So I've just nudged David into grabbing one as well. at the top there, it's not just about thinking about individuals and the environment they're in, it's about building collective action. It's about bringing together social direction, and that's exactly what Andrew, exactly what Sanchia have been talking about, exactly what you've been hearing about, bringing collective interests together in the same room. At the end of the day, we're all human beings that share a passion, share some history, some language, some values, and if we come together, we can build something. And when we build something successfully, it breaks the outer circle, and the outer circle there is healthy public policy. How many things in our public policy are unhealthy or set a default which is unhealthy? What a great act it was when Vic Health was created to use to legitimate withdrawing advertising. Isn't it fantastic? I was just discussing with Andrew earlier this weekend, I think it's being announced around some restrictions on gambling advertising, particularly during sporting events, right? Isn't that a wonderful step forward? However, that's, an incredible step forward. Wouldn't it be marvelous if we did the same thing to alcohol? There's the same exemption exactly applies also to alcohol. So, and there's no, it's a constant call, right? The problem is most public policy decision making, in my experience, is driven by interests, it's driven by demand, and unless we demand to speak for health, nobody else is going to do it. We've got to demand to speak on behalf of those issues that we know and we care about. The last thing there, and right at the bottom, and I've left it to last, obviously, because I'm talking about health, is reorientating health services. And fundamentally what that means is thinking about our health services as exactly that, health services. Not just curative, not just queue waiting, not just referral system patterns and protocols and a bunch of rules and a bunch of things that we do to bodies, all of which is brilliant. And if I'm sick, I'm the first person who wants to get them. If my loved one is sick, I want to get those quality services. But think about reorientating them towards prevention, towards collaboration and partnership that is led and owned by clinicians working for their patients and with their patients to progress a wider health agenda. So if we can put those 5 things together, we will get action, and we do get action. And Australia has some incredible runs on the board in relation to this. Another great achievement just the other day, we've managed to face down another threat to the plain packaging legislation on tobacco. Fantastic work by Cancer Council, by many other leading advocates, by many federal MPs who stood by, regardless of their partisan situation, regardless of their party interests. And interestingly enough, in the discussion around plain packaging, it is definitely the case, without broaching confidentiality, that the medical and nursing and professional backgrounds of a number of members of parliament made a meaningful contribution to getting that across the line. That's a great example. We've got a leader in the Greens who is a public health physician. Richard Di Natale. Incredible leadership there that we need, and we need more nurses, absolutely, and we need more out and proud nurses in the federal and in all levels of government. So if you're not active, please do get active. So that's how we promote health. So I've told you all the stuff you already know, okay? So you know about what health is, you get that. Everybody in here gets that, that's totally patent. That's how we do it. We don't just do it by preaching to people. We don't just do it by telling them off or making them miserable. We do it by all of those different actions summarized in the Ottawa Charter. So nurses, I don't know what's happening here. Nurses promote health. That's absolutely key to your role, and you do it in so many different ways. So many times spent with members of the public, who are your patients, with other clinicians, in environments, talking, providing advice, providing support, out in the community, in different places, and in your everyday conversations at the barbecue. You're already promoting health. The big question is, how do we do it better? Now, as a good friend of mine once said to me, Bruce, I make it my role to make sure that I don't give advice to anybody over the age of 2, right? Very respectful of the collective wisdom in this room. I'm not about to patronize you about how to do your jobs better, but I will share some insights that I've picked up along the way, working particularly at the wonderful institution that Vic Health is. And the first thing I'd like you to think about a little bit, and there's tons of research on this, you can look it up online, there's some really good tools and resources, is if we want to get better and smarter at changing behavior, let's go east. When I say go east, what I mean is use this framework. This is a framework developed by the UK Behavioural Insights team, which had the privilege of working with recently as one of our leading thinkers, Dr. David Halpern, who is a senior advisor to Tony Blair, chief strategist for Tony Blair, and then a senior leader as well, also for David Cameron, before setting up the Behavioural Insights unit, which fundamentally is all about how do we change behaviour. And what they've done in this framework is synthesized an enormous amount of research into 4 simple things that if we do it, will increase the likelihood significantly of behavioral change. It certainly doesn't guarantee it. There's no silver bullet in behavioral change, but it will get us along the path. The first word up there is it needs to be easy. What is easier than just reaching out ahead and grabbing one of those Mintos? It's so easy. I never buy DVDs, right? I never buy them. I haven't bought them for decades, right? Now I've got a smart TV at home. I can download movies for the same price off Google Play that I would pay for them in the shop. And you know what I do? I download them. Why? Because it's easy. Why do you think we've got Wave cards? You know, pay Wave cards? It's not because out of some spirit of generosity. It's because people spend more money. They spend a lot more money. If you want to save yourself some money, just deal with cash. Yeah? You'll save a lot of money. Pay Wave is an incredible way of spending more cash, right? Ease of use. You've got to make it easy. It's got to flow, okay? It's got to flow through. The easier you make it, the simpler the change is going to be, the more likely it's going to get taken up. The next one there is make it attractive. And this is something where in health, we're really, really, really good at describing problems, right? Cancer, it's dreadful. Heart attacks, they're awful too. The disability associated with them, well, that's terrifying. Dead, oh, that's even worse. Dying, that is the worst. That is like that is the scariest of the scary, right? Those are the problems, okay? The problem with the problems is they're not necessarily the same thing as the solution. By that I mean, if you take a problem-centered approach, we'll often look at, for example, tobacco smoking, let's say. And we can say, wow, that's incredible. Aboriginal people in this country die 10 to 15 years younger than non-Aboriginal people, and half of that gap, half of it, is accounted for by smoking rates, right? So we can say, well, let's solve the smoking problem, and that gives us a focus. But to solve the smoking problem, we have to look at why is the prevalence of smoking so much higher in the Aboriginal community? What are the underlying determinants and drivers of that prevalence, and unpack that. It's not as simple as just saying, you know, you want to avoid getting cancer, stop smoking. It's a really great message to say to get someone to stop doing something. It's a lot harder to do if you're wanting to get somebody to do something, right? And particularly to take up more complicated behaviors like exercise or changing diet and those kind of things. So we've got to try and make it attractive. And I think we had a great keynote on the first day from those 2 amazing guys who took such a simple idea around, you know, getting washing machines out to the general public and turned it into an amazing solution to a problem they didn't realize was a problem to some extent, yeah? So we're really good at defining the problem a lot of the time, but we forget that we've got to make it attractive to people. And attractive doesn't have to be pictures of people gambling through flowers and jumping about in leotards, right? Attractive can be all sorts of different things to different people. The next thing down there is you're going to increase your likelihood of better behavioral change outcomes if it's social. Did you know that? It is far more likely that you are going to live up to a commitment to a behavior that you might want to change if you've written it down. But even better than if you've written it down in your diary or somewhere else is if you've said it to another person, and even better again, if you've said it to multiple people. Why? Because there's a sense of, we are social animals. Human beings are social animals. We're in a room here. We are being social together, right? Our environment leads us towards towards that social outcome. So you can increase the likelihood of behavioral change if you have a social component built into it. The final bit there is it needs to be timely. The hardest thing about behavior change is going, tomorrow, Michelle Bridges, I'll bring out the true me. The real me, Michelle, will come forward maybe next week. Making things timely means making a commitment in the now, or making the decision context very, very, very circumscribed and very, very close together. Often in health, we're talking about long lead times, and particularly when we're talking about behavioral change, you're saying, but I like the beer now, Bruce, you know, or last night I liked the beer, today I'm regretting it. But You know, I like my Mars bar now or whatever else it is. Obesity and heart attacks are miles away from me. Right? There's a big temporal gap between what I'm doing now and my outcome out there. I've got to link those two things together in a much more temporal way to get a better outcome. So I'm going to kind of unpack what this framework means and a few examples that we've worked on at Vic Health to illustrate the point. One of the simplest ways we can promote health is to change the default. When I was a boy at school, our school had a big catering thing. You know, you'd go into the hall, and to get your lunch, and the first tray at the lunch counter that most kids didn't get past was chips, and the second one was baked beans. The salad was right down at the bottom end, right? And I can guarantee you, even from those misty years ago, most kids never made it there. It was chips and beans a go-go, right? Well, why on earth would you not? Chips and baked beans. It's like manna for heaven from kids. It's amazing. So why would you possibly make it? All you got to do, and it's very simple, is put the salad first, still have hot chips there, but you've got to ask for it. You could even have a little sign saying, you know, ask if you'd like hot chips. Pop it at the end, after everything else. What's really interesting about these things, as I'll go on to talk about, is that often when it's really effectively done, nobody even knows it's changed. No one even recognizes the fact that it's changed, and we don't have to expend all of that cognitive effort to getting us over the finishing line, as it were. I think a really good example of where we can practically change the default is by taking the sweeties off the tables and off the GP reception desks, please. When you go back to your practice, have you got lollies on your reception desk? Oh, what message are you sending? Health people, what message are we sending when we say, I know, let's have a fundraiser for kids' sports, which involves selling chocolates? Because the obesity epidemic is going to be solved by physical activity, right? No, wrong. Okay, it's going to be solved by eating food, not too much, mostly plants. That's what's going to solve it, right? Running around will help. Doing a bit of exercise will help. It's mostly about eating less, eating more proper food as opposed to highly processed food, eating less of it, and focusing on those key bits. So thinking about changing the default, what message are you sending? It's just good branding, right? It's just good branding. It's just selling that message, but it's also the nudge that you're going to give people around their behavioral choices. The next one over as well is we've got not just everybody knows, we should be exercising more, but what they recognize less is that we've got to be sitting less, right? If you sit, we're not designed to sit. We are designed to move. Right? We're not designed to sit, but we are biologically programmed to minimize energy expenditure. We don't think about it, we just do it. Our entire evolutionary heritage pushes us on a road towards minimizing energy expenditure by sitting. If we have the opportunity, we will do it. The problem is our environment now means we are sitting more than ever before. We sit when we're at work. We sit getting to work. When we get home, we sit down and look at screens. So getting people to stand up actually has independent cardiovascular benefits. This is proven in a randomized control trial, which we worked on with Baker IDI, has independent cardiovascular reduction effect of workplace standing stations with a small program to support the transition from people who are usually used to sitting down at their desk to occasionally standing up. I've got one of these wonderful things in my workplace. I've got a slightly flashier version, but you can make them real simple. And they're not that much more expensive than just anytime you're going to buy office furniture. And for me, if I've got an hour or two and I'm sat behind the computer and I'm starting to kind of, it's getting hard yards, get your blood pressure up, stand up, pay attention, get your mind focused, and reduce your cardiovascular risk, all in one little burden, in one little pump there. So standing desks and changing the default on our food catering choices. Something which is really exciting as well, I'm going to come on to in a sec, but bearing in mind we should probably be standing up, let's all have another little stand up for a sec. Bit of a stretch out. Okay. You can remain standing or you can sit down. One of the things that I find really interesting as well, at Vic Health, we practice standing meetings. And what happens is when we've got externals coming in, we all say, we're all standing up and everyone thinks we've got bad backs. if you want a little behavioral cue for how you can do a standing meeting, what you've got to do is if you're, or not all standing meeting, if you're sitting down at a long meeting, if you're working with social workers possibly, Sanchi, you can pull back the chair. What you've got to do is you can't remain at the table. You've got to walk back to the wall. Okay, it's really weird. Otherwise, it comes across as like super threatening to people if you just stand there, right? So you can just stand at the back. And usually people will think you've got a bad back. But, you know, that's okay. Maybe one day if we spread that germ, it will infectiously get everywhere else. Feel free to sit down if you want to. It's fine. If you want to keep standing, you can as well, of course. So I'm going to talk in a little bit of detail now about an amazing piece of work that we worked with the Behavioural Insights crew, Deakin University, us at Vic Health, and also our Behavioural Insights crew from the UK, and now in Australia they're doing a lot of work, including actually in Commonwealth, but also in the Victorian government, New South Wales government, and elsewhere, on an incredible program of work that most people wouldn't ever know has occurred because it is so effective. And this was with the Alfred Health. And what happened at the Alfred, I'm not going to go through, and the slides obviously will be available, and you can see this stuff, and there's a number of reports we've written up about it. We were interested at looking at sugar-sweetened beverage availability. So it's a big hospital. The Alfred is big. It's one of Victoria's biggest. So it's got a lot of catering going on. It's got canteens, it's got vending machines, it's got a whole host of different stuff. And all of them have a variety of drinks. You've got red drinks. The red drinks are the ones, obviously, that are high in sugar. The amber drinks, which are somewhere in the middle, and the green ones, which are minimal or no additional added sugar. And what we wanted to do was run a series of randomized control trials in that environment, looking at changing the price, the promotion, the availability, the advertising of those to look at the impact. Now, there's a number of different trials there that we did, or that the Alfred led on and that we supported. The first of which was about basically at the counter in the canteen, behind the counter, you've got all of the beverages up, and there was the Coke, full-strength Coke was on the counter behind it. All that we did in the first trial was take the Coke and put it underneath. That was it. Just put amber and green on top and the full-strength Coke in the cabinet underneath. What effect did it have? It led to a 28% reduction in sugar-sweetened beverage consumption of the red drinks. 2 people noticed, and they both didn't drink Coke. Incredible. But even better than that, those drinks, they still sold drinks, they just changed the drinks people were buying. There was more amber drinks bought, and more green drinks bought, and the operator's financial line stayed flat, right? It started as a 6-week trial. Oh, we need just a bit more data, It's still running now. Okay, so just taking them down. Another quick example, we changed the price for the full-strength varieties of Coke in the vending machines. It had a significant effect. We changed the relative position of the drinks in the vending machines so that at eye light, the eye line that you see is always going to be water, and that the Coke is going to be moved around or invisible. And again, you could ask for it and you would get it, or you could root around in cupboards and you would find it. But there's just that friction. It took that little bit more effort to seek it out. Those also had similarly significant effect sizes while not affecting the bottom line. An incredible piece of work led by the Alfred that everybody who works in a healthcare environment should be familiar with. And if there's one thing you take away from today is go back to when you go back to your workplace, look at your vending machines, look at your catering, and think about what potentially could you do that wouldn't cause massive ructions. There was no riots, unlike when we tried getting prisoners that smoke in Victoria to stop smoking. There was no riots to do that. Nobody even noticed. It just happened in the background, and it's a great example of changing the default to make the healthy choice the easy choice. And when I say choice, you've got to realize most of our choices aren't conscious. They're actually unconscious. We've got a certain amount of cognitive bandwidth, and we expend it very, very quickly. There's a reason that confectionery sits right at the end of the supermarket. Because when you go into a supermarket, you've got a lot of choices to make, right? Now, you might have gone in there, and most of your choices will be default, right? You'll be going, I'm getting my usual things, right? I'm getting my usual things. But you've got to make some other choices. Oh, they don't have this available, so what am I going to get instead of that? You're making all these choices, and you're expending all this cognitive energy, and your bandwidth is getting worked up, and you get it worked out, and then you get to the counter at the end, and then there's a chocolate bar there, and I've earned it. I've earned it. And it's just enough to just nudge me over the line, right? Most of our choices are not conscious choices. It's usually when people say choice, what they think is that it's conscious. Actually, most of our choices are not conscious. They are pre-conscious or subconscious, then with a bit of cognitive stuff put on the top of them to rationalize them post hoc, broadly speaking. So changing the default, that's an incredibly powerful thing to do, right? Make it easy in your life. When you go home, look at the size of your plates. You want to lose weight? Use a smaller plate. Literally, it's been studied comprehensively. Plate size, people eat to the plate. Kids eat to the plate. You have a smaller plate, you eat less. Look at the size of your glasses. Have big water glasses, put them on the table with water next to them. The Coke can still be in the fridge, but if it's got a little epoxy glass and it's stuck in the fridge, it's a lot easier to be going for the water on the table with a fun, nice-looking thing. Flavor up your water. You know, put some lemon juice in it or whatever to make it a little bit more palatable or approachable if you're really averse to that or you're trying to get out sugar-sweetened beverages out of your life. The next bit then is about, so changing the default we've done. The next one is stay positive. Why do we need to stay positive? Well, I've tried to do you some positive affirmations in our amazing MCs today as well. I've done a lot of work on the positive affirmations front. Positive affirmations work. They might feel cheesy, but they genuinely work. They improve your mood, they improve your resilience, and they will improve your ability to stick the length of the race, as it were. And one of the hardest things in health promotion, one of the biggest barriers, particularly in clinical environments, and this comes back from study after study after study, is that people say it doesn't work. You know, if they can get over the hurdle of talking to a patient about maintaining a healthy weight, which is a pretty tough conversation, you know, if you don't have the training, if you don't have the background in motivational interviewing and so forth, it can be a tricky conversation. We can come back to that. I gave them the advice. It made nary a bloody ha'porth's worth of difference. You know, they didn't stop smoking. I saw them again the following week. I said, well, I told you it didn't stop doing that. And it didn't work, right? But think about it like this. I'm a 14-year-old lad at school. This is me, right? I didn't particularly want to be interested in smoking, but, you know, a lot of people around me smoked. I occasionally smoked a bit. I moved out of home when I was 17, and I went and worked in bars in Edinburgh, just as I turned 18. And to have a break in the bars I was working in, you had to have a smoking break. You'd stand at the end of the bar, because you could still smoke in the bars in those days, and you'd have a cigarette, right? So then I became addicted to tobacco in that environment, right? As a result of that behavioral prompt. Was that because of me? Was that because of the environment? A mix of both different things. My life progressed. I got all this health information, and I went, yeah. Why am I worrying about something that may not affect me for another 50 years? I'm not going to be particularly concerned about that. That's a risk that's a long, long way away from me. Then over time, I became more interested and engaged in health. I started working in health. I got with a partner. We settled down. I started getting asked personal questions, and I quit. That was my journey. Other people's journeys are going to be different kind of journeys, and we know on those smoking journeys, it will usually take between 5 and 15 attempts for somebody to quit, depending on how you define attempt, right? Because you can go, oh, I'm going to do it, and then never quite get around to it. So it's going to take a lot of effort. It's going to take a number of repeated efforts to get there. What is the role of the practice nurse in doing that? It is incredibly rare that you as a practice nurse would speak to the person at exactly the right moment, that not only are they going to quit, but they're going to quit it and you're going to see it. That would be phenomenally rare, right? But because we believe, that behavior change, for us to be doing behavior change, we have to witness it in front of it ourselves. We put ourselves off, right? But think about this, right? Penicillin, it's a miracle drug, but it doesn't cure everything. The antibiotics and the drugs that we hand out, even if they're incredibly efficacious, might work for, let's say, 25 to 30%. Like, we categorize that as an incredibly efficacious drug, right? But we feel good when we hand out the medicine. We feel like we've done our job because we've given them the pill, right? Even though actually that infection would have probably resolved itself if we hadn't have done that in the first place. And we never know which one was cleared by the drug and which one just cleared itself and X, Y, and Z, right? We look at the cases right in front of our face. So health promotion is like this. It's a drip, drip, drip. The information that you provide is absolutely critical. And I'm going to come back to this, but this is something that David kind of turned me on to a while ago, which is that for 22 years there's been a survey of professions in Australia, looking at trust and ethical behavior and engagement. And for 22 years straight, that survey by Roy Morgan has pulled out nurses as the single most honest and ethical profession in the eyes of the public. Congratulations, nurses. As David Morrison said, the ex-ADF leader, when dealing with those incredible, terrible cases of gender-based sexual assault and related activity in the ADF, he said, the standard that we walk past is the standard we accept, right? Now, what I'm going to come back to is, we don't have to be perfect, right? I drink. I still, and I'm very proud of this, working in tobacco control, although my colleagues in tobacco control would hate me for saying this, I still have an occasional cigarette. Like I've been working in tobacco control like 15 years, and it freaks everyone out. Go to a tobacco control meeting and go and have a ciggy outside. We don't, well, I'm going to come on to this. I'll save my next bit and I'll contextualize it in a little bit. The point is, behavior change doesn't happen overnight. Nurses are trusted. Your patients, it might not feel like it, but they listen to you. They just might not do it when they're looking at you. Just remember that, yeah? And the standard that you're walking past is the standard that you're accepting. If a patient that you know their condition is related to a behavioral factor that is modifiable, be that alcohol, be that smoking, be that nutrition, be that whatever else, if as part of your clinical assessment, you're not taking seriously the opportunity to have a conversation around that, is that cool? I'm not going to give you a hard time because you've got real hard lives. Maybe what the gap is there is the language to talk about these things, right? And that's going to bring me into my next point. It's about the focus. When we talk about lifestyle and behavior and health promotion, often we talk about smokers. We talk about overweight people, obese people, drinkers, people. What you've got to separate out is the person and the behavior. Shift the focus. Nurses are amazing, and Sanchi was just explaining earlier, at treating people in a non-stigmatized, inclusive way. So that when a man comes in and sees you, when a woman comes in, when an old person, when a young person, when someone from a different religious or sexual orientation comes into your practice, you treat them the same, right? They're presenting, they've got a problem, you're helping them with the problem. It's exactly the same with behavior change. Behavior is not a property of the individual. I've just explained that. Right? If it was a property of the individual, then we'd all be, I don't know, like smokers are not our enemy. Smokers are our friend, right? We want to work with smokers. Smoking is the problem, right? It's not the smokers. So you've got to have that focus. And to help have that focus, do those classical things that they always train up. And if you haven't had training in it, definitely a place to go back and maybe think about for your PD. Motivational interviewing, 101. Right? You don't get to yes through having a no-based conversation. So rather than, you should, so do you smoke? Well, that's you shouldn't smoke, don't you? Where's that conversation going? It's not going to open up. So I see on your information here that you're a smoker. Did you know that? I can link you up with talk-based therapies and medical therapies that are proven to increase the likelihood of successful quit attempts. Did you know that? It's just the difference between a closed and an open question. Ask it openly. The person can say, no, I didn't know that. Well, do you want any further advice? Or not, as the case may be. It's not judging you. It's not passing judgment on you. It's not laboring the point. It's just asking the questions in exactly the same way as you would any other aspect of your clinical practice. So getting the focus right is absolutely key. And we do need to think, of course, about leading by example. That says, do not sit, climb, or walk on the wall. Congratulations, doing a great job, guys. Right? But then we get a bit hung up, right? Because we go, I still smoke, Bruce. I enjoy, a shandy occasionally. I'm not like some kind of weirdo lycra. What do they call them? Mammals, the mammals? Middle-aged men in lycra, on the bikes on the road. I'm not a mammal, I'm not one of these weird health Nazis. It's not about being perfect, right? It's just about caring caring for yourself, caring for others, and remembering that health is not a goal in itself, it's a resource for living, and that health promotion is the process of helping ourselves all together build that better resource for living. It's not about being perfect. It's not about blaming individuals. It's not about saying smokers and overweight people. It's about looking and changing how we create our environments, how we skill ourselves up, how we mobilize as a community to change the environment in which we live, either the physical environment in which we live and work or the public policy environment, which ultimately does have a huge role to play in determining how society is organized. So I started off and I told you a bit of a fib. I'm just going to close now. And the fib that I told you is that I said I was only going to talk about putting the health in healthcare. That's not true. Because the magic happens, as we all know, because nurses are amongst the most skilled people on the planet at doing it. The magic happens when we put the health and the care together. Thank you very much.